Hello and good morning and good afternoon and good evening, everyone. Thank you for taking the time for this webinar. There may be some technical issue in terms of when you enter the webinar, you may need to rename yourself. Not 100% sure why you're all appearing as myself, but if you don't mind, please rename yourself by hovering over yourself and then clicking on the more button, and there should be a rename option. If you have any issue, please let me know and I can help you do that as well. Thank you so much. Hello, everyone. Thanks for taking time for this webinar. I think we're just going to start maybe 3 minutes after to allow for everyone to sign on, just in case they encounter any connectivity issues. And I see that more people are trickling in. So thank you for waiting. Oh, hello, good morning, good afternoon, and good evening, everyone. Thank you for taking the time to join this webinar. So my name is Tracy Yuen. I'm a consultant working in health information and digital health with the Division of Pacific Technical Support in the WHO office here in Fiji. And thank you for joining us for this first of the webinar series focused on International Classification of Disease 11 Revision, or ICD-11. So as some of you may be aware, ICD-11 was adopted at the 72nd World Health Assembly back in 2019 and officially came into effect the 1st of January 2022. And since then, WHO has been supporting member states to successfully implement and also report through ICD-11. So as part of the systematic support that we're providing to the Pacific in terms of implementing and transitioning to ICD-11, this is one of the first steps. So this webinar series will provide a high-level introductory information in terms of what ICD-11 actually is, the resources and tools we have available to support you in this process, and the type of technical support that we're providing to member states, and also to share with you country case stories on how they went about implementing ICD-11, so that at the end you have a more concrete understanding of what ICD implementation may look like for your country, and also a bit of background knowledge when we work with you one-on-one to implement more country level support that will follow. So you may notice that in the webinar invitation, the target audience is quite broad. So this is to emphasize that successful ICD-11 implementation is beyond just medical coding. So we do hope to engage all those who interact with coded information. So whether it be statisticians, civil registers, healthcare professionals, or health policymakers. And it's great to see that some of you have took the time to join this webinar, and we hope to have more diverse audience moving forward. So please feel free to share this webinar that will take place monthly moving forward. And to drive home the point that collaboration is necessary for implementation of ICD-11, great to see that we have our partner agencies that are part of the Brisbane Accord Group, and also within WHO, colleagues across the 3 levels. So we have colleagues from headquarters in Switzerland and also from the Western Pacific Regional Office, despite the large time difference. And of course, we have representatives from the Ministry of Health in Malaysia and also in Samoa, who will be sharing the country experience as well. So in this first webinar, it will focus on providing an introductory to ICD-11 and also the implementation steps. There will be a question and answer period at the end, but do make use of the chat function because we hope to get your comments throughout and any questions that you may have. And just to make this a bit more interactive. And to kick us off, I will turn it over to Dr. Robert Jacob, who is the unit head of the Classification Terminologies and Standards Unit at the WHO office in Switzerland at headquarters, who will be providing an overview of ICD-11. So over to you, Dr. Jacob.
Thank you, Tracy, and welcome, colleagues. Very glad to speak to you directly. So let's start very quickly with an introduction, giving an overview of ICD-11. Now, one important thing to know is that, as the colleague was saying, it's a legally mandated global national health information standard. It's in effect since January this year, and countries are step by step adopting it. And that ICD is also very important because it's independent of language and culture, so that comparison of data and is possible across different language regions and cultures. Now, why ICD-11? It has been clinically extensively updated during the revision process, and it also is a technological advance, meaning that was formerly 2 different books, now is integrated into one. So the terminology part, formerly called index, and the classification. And as a result, the ICD-11 is much easier to use than ICD-10. Usually then the coding is more accurate and we get better health information. And in the end, we improve health. ICD doesn't come alone. We have an interventions classification, ICI, and an ICF. And together, both of them, all of them use what we call the international extension codes of WHO. It's also a terminology component of things that WHO produces anyway. So, for example, the generic names of medicaments, devices, the tumor description, anatomy, and many other things pre-existed. And this we also link to other information systems that are more used in electronic environments. Now, the vision is, of course, input the data once in some record, then you can reuse the information for many different purposes. That was always the case, but now electronically, it's even more important and even more feasible than in the past if everything was exclusively done on paper. Now, continuing on this, just to remind everybody that ICD always was more than diagnosis, and also ICD-11 is more than diagnosis. Of course, we have diagnosis, injuries, findings, other things, but also in ICD-11, we have now newly something related to traditional medicine conditions. We can assess the functioning of a person, document the functioning of a person. And like ICD-10, we already have something like severity. Similar things in a non-systematic fashion existed in ICD-10. In some places, we have extra anatomy that can be coded. We can code on which side something occurred. Of course, all this additional information is possible if, as number one, it's required by the data use in your country, and also if the documentation is there. Of course, if it's to be very simple, we just remain with the green part, classification and terminology. Now, one brief insight into the structure of ICD-11 so that you understand why ICD-11 has these features, how this is done. And you see here in blue the dots. So this is the part that is classically a classification. In ICD-10, if you think this in ICD-10, you would have 3 blue levels. And you see here we have a little bit more detail. But what is also interesting, that is the hidden part, that's this yellow part, that is also a same knowledge structure as the top part with cross-references internally. And this allows the system, the computing system, to tell you code elsewhere, to tell you excludes this, and also to understand when you type something more complicated that maybe this is to be covered by a code combination. Like in ICD-10, you had dagger asterisk, for example. Here you have other ways of doing these things, but it's similar. And as a result, we have this blue part that has some 17,000 categories, very similar to ICD-10. But if you include the yellow part, then you have 85,000 entities. And as some terms can have synonyms, we have some 134,000 terms at the moment. And because we have these cross relationships and the system is intelligent, so it can understand some parts of natural language, we can, for example, the system can recognize if you code directly more than 1.6 million terms with combinations. Of course, sometimes clinical people use adventurous combinations, and in that case, still manual coding is necessary. But for this, there's also an updating mechanism that allows us to add such terms so that next time you encounter this wording, the system will automatically help you and you don't need to look up manually. And this is what we mean with a Google-style searching, that in principle, if you have no idea, you still can do some search like you do it in Google. In the end, the ICD-11 is still used for statistical use, but it's now more clinically oriented so that you can keep more detail in the documentation if necessary and required. And we have seen that clinicians or those who provide the primary input, if they see that you can do more detail and more detail is retained in the data, are also willing to document in a little bit more precise way because they see, yes, it matters to the data. Now, with all these fantastic structure, you can then do something like this. Here we see the multilingual version online. If somebody goes to the ICD-11 browser, you can search for something in one language, and then you can choose with this click box on the side which other language you need. I think in your region, clinically speaking, French and English are the most relevant. That's why I'm showing this combination here. But you will have step by step also many other languages as soon as they are translated. Now, the result, what does it mean? Easy to use. For example, if you want to code something like osteoarthritis right knee, and you go to what we call the coding tooling, then the system will happily give you an output, and the topmost is usually the one that matches best what you have been entering. And you see here a code for osteoarthritis of knee, unspecified because, well, no more information is given. And the word right is interpreted by the system with a code that it identifies right. And you see here this at XK9K, that's the code for right. What your setup in your country, in your region, in your environment depends really on the national need. This is for demonstration. Some people say, oh, this sounds so complicated. And if we show it without this combination option, they say, oh, I cannot code all the information that I want. So in the end, it's your decision, your environment's decision to say how much detail you go. The minimum detail that you have to go is what we see here as FA01, so the one before the dot. Now, looking at some examples of updated content, why we do the ICD-11, just a very few examples. For example, chapter 1, influenza moved into chapter 1. We have the possibility of coding all kinds of antimicrobial resistance. This may be relevant when it comes to documenting detail with international agreement. So the global antimicrobial resistance surveillance system depends on the integration with your system. We have now stages for HIV, for example, and the way sepsis is now coded in the system corresponds to the most recent understanding for sepsis. Also, if I say most recent, well, this most recent convention is already 5 years old, but don't forget, ICD-10 is more than 30 years old. Now, chapter 2, for example, we have added the tumor morphology in many places, so that more detail can be coded. But however, don't worry, also if you do not have the morphology, only the tumor site, and whether it's a cancer or a benign tumor, you can also code simple. So it's all taken care, taken into account, so that if you have sophisticated information, you can code the sophisticated information. If you have simple one. A new is that you can code basalioma. We have subtypes of melanoma, and uncertain and unknown behavior has been split into unique categories, because there is a difference etiologically between the meaning of uncertain behavior and the fact that you do not know the tumor behavior. For diseases of the immune system, for example, is a very new chapter. This previously were parts of chapter 3 in ICD-10. Other diseases were formerly in the musculoskeletal diseases section. So now it's all grouped together, that finally one can see also at higher level statistics whether there is a frequency, what is the frequency of the immune system diseases. And this is relevant because the number of these diseases seems to be increasing. We have here in chapter 14, diseases of the skin, for example. This has been really completely reworked. There were some content in the classification structure that suggested that maybe the last update was done in 1948. Of course, this is not true, but the structure was totally outdated, and in a big international effort, this has been redesigned. Of course, all the diseases that have been documented, are clinically documented, are still codable, but the structure will be new, is new, has to be new to make meaningful information out of what is coded with this. We have a new chapter that is conditions related to sexual health. We have sexual dysfunctions, pain disorders, and gender incongruence, all conditions that are not strictly linked neither to mental nor to bodily conditions. And here a brief overview of some of the changes that are there. So several diseases that have specific infectious agents have moved to the infectious diseases chapter. A very important move is to moving back cerebrovascular diseases into the nervous system. The things that are coded with cerebrovascular diseases are essentially the same as they were in ICD-10, but now it has moved over this. And then many things that were scattered across chapters, for example, pain in joint or cardiac arrest or hemiplegia, moved to the signs and symptoms chapter, so that in the organ chapter, we have the real diseases. Finally, for example, brain tumors and tumors of the hematopoietic system are now grouped together, no matter whether they're benign or malignant, because the brain tumors behave problematically if they grow, because the tissue cannot expand, so that we have pressure within the skull, and they're as bad as malignant tumors. And for the hematopoietic system, for the blood system, the scientists change from time to time whether it's a benign or a malignant tumor, and grouping this together allows so that the grouping remains stable. Nevertheless, you can code whether it's a benign or malignant tumor, but at higher level, it's grouped to the brain and to the blood and not subdivided by benign, malignant, and so on. And then one thing for morbidity coding, the main diagnosis in morbidity has been updated in ICD-10. It was the main reason for resources, the main resource consumption condition, and now it's the main condition for a reason for admission after the end of the stay. So what does this mean? This means if a patient comes with cough and then a lot of diagnostics are made and it turns out, oh, this was a pneumonia, then the main condition is pneumonia, of course, not cough. So that's one of the changes here. Finally, things that did essentially not really change are conditions included in the following chapters. So anything that was in the maternal conditions chapter has remained there. Similarly for prenatal, injury, tumors, and external causes. In all these chapters, you will find more detail, some changes in the structure, but what has been there has remained there because these are major public health tracers. And finally, the mortality coding rules have kept exactly the same meaning as they were in ICD-10, but we needed, of course, to adjust them here and there to match the new structure in ICD-11. In summary, I can say that ICD-11 is much easier to use, so there will not be that much training necessary as was the case for ICD-10. This saves also coding time, and coding software integration is possible because we have this natural language processing, because we have this expandable list of synonyms, this kind of concept of the foundation, you remember yellow dots, and post-coordination, you remember code combinations, that's a new word for code combination. And then we have this online and offline software integration, application programming interface. This means if in your office at some point you enter the data in an electronic environment, all these features, Google style like coding, can really help you, but of course, offline use is possible. So you don't need to be in the internet. If you have just a local system, everything will be fine. We can have the accurate detail coded so that we really can record once and use for multiple purposes. We have this scientifically update. We have all these clinical terms that we were discussing before, and you can do all kinds of safety reporting or extract the data for safety reporting if this is in place in your country. And we have taken into account many clinical modifications when redesigning. The other thing is it's multilingual and international, like ICD-10. It provides standard encoding. And for the techies among you, this application programming interface can understand FHIR and some other ways that software talks to software. Finally, we can even print ICD-11 if necessary and use it on mobile devices. But of course, be aware if you print it, you don't have the Google style search, of course. Online maintenance is there with global participation. You just need to self-register, and this means open access and open processes. And finally, ICD-11, you don't need any licensing. It's free to use. It comes with all the toolings. So as soon as it's running on your local computer, or you access it through the internet, or it has been integrated in your national software that is used, you don't need to do anything more to use it. And you want to know where is the world with the implementation. So I just say the darker the color, the further progressed the implementation is. And you really would wish that soon also the Pacific region can have many darker blues in the map. And you see here some countries are already producing data, others have just done the translation, others have national policies and start rolling out. So that's a little bit the picture of the world. with this, I come to an end. And yeah, I hope that ICD-11 can be used easily and nicely in your environments. And this arrow points you to the website, icd.who.int, that really gives you all the information, gives you access to the browser, gives you access to the coding tool, gives you access to extra guidance, and even in the so-called maintenance environment, gives you access to you, all of you, to register yourselves and provide input, say, we need this term, or maybe this category could be reshaped. But if you make a proposal for amendment of ICD, add some evidence why this is necessary, because many people always have many opinions, and we need to make sure that everybody can be equally happy with the coding of ICD-10. With this, I come to an end and would hand over to my colleagues. Thank you very much for your attention.
Thank you very much for that presentation, Dr. Jacob, and for setting the scene, so to speak. So to bring this information and relate it to the Pacific, I'm going to briefly give an overview of the current ICD implementation status in the Pacific before turning it over to our colleagues from the Ministry of Health in Samoa, who will go into a bit more detail on the implementation in their countries. And let me just share my presentation quickly. So in general, across the Pacific, ICD-10 is currently predominantly used, but we do recognize that in some countries, coding using ICD is not actively being implemented. And in terms of the level of implementation and coverage, it is typically higher for mortality, so coding of causes of death. For morbidity coding, it is currently implemented in a select few Pacific Island countries and areas, and typically in a hospital-based setting. And in terms of the workflow, it is largely centralized in that records typically are transferred to the national levels, and you select a few with the appropriate skill sets then conduct the medical coding. And this is largely situated within a paper-based environment. And this is particularly true for mortality coding. So typically death records are transferred to the national level. And because we're in the Pacific, records from outer islands some of you are unable to see my slides. Let me try to share them again. Let me try to share my screen again. Will you please let me know if you could see my screen now? Nina, would you mind if you stop sharing your screen?
I think he froze.
Okay, let me see if I could try to do it on my end. Apologies for the technical difficulties.
I think, Tracy, now it should work normally if you try to share.
Okay, I will try to share my screen again.
Okay, we see it.
Wonderful. Okay, so where I left off was talking about the workflow for mortality coding. So because we're in the Pacific, death records typically have to travel to the central level through various means. So this for records in the outer island, this may mean that they need to travel via boat at the risk of being water damaged, or they in areas where there are greater connectivity, they may be transferred through informal channels such as pictures over email or through Viber and WhatsApp. But once the record reaches the central level, it is then coded and entered into a database. And in terms of the use of automated tools such as IRIS, a lot of countries have expressed interest, but its implementation has been limited. And this is in contrast to morbidity coding. So for the select few countries that have implemented it, it is typically in a hospital-based setting. So it is linked with their electronic health records, but the form of the linkage tends to differ. So in some countries, it is a drop-down list of the most common conditions. For other countries, it is a direct linkage of the entire catalog of ICD-10 coding where one could search using keywords. And because of some of the things that I've mentioned and other factors, there is quite a variability in terms of the quality of the coded information. However, this is largely based on anecdotal evidence because formal quality audits are not consistently done across the Pacific. So in terms of the technical capacity and human resources available to support the coding needs in Pacific Island countries and area, this is a noted gap. So typically, there is 1 or 2 individuals with the appropriate training and they're supporting all the coding needs within the entire country. One can make the argument that the volume of coded information is smaller in Pacific Island countries and areas, but there really needs to be a more sustainable and innovative solution in terms of developing in-country capacity in this area. And moving beyond just looking at the coding of information, there is a general limited use of the coded data at the end. So for some countries, we see that they generally develop a list of the top causes of death that is part of their annual or quarterly report. However, the full benefits of having standardized and coded information is not fully recognized. And with this brief overview, I will now turn it over to our colleague from the Ministry of Health in Samoa. So Ms. Bruda Olivias, who is the Senior Patient Information Officer from the Ministry of Health, who will be sharing more detailed information of the current ICD implementation in the country. So over to you. Let me try to see if you're online at the moment. Buda and the Ministry of Health team in Samoa, please let me know if you have any issues unmuting.
Are you with us, Tracy? Samoa here, we don't have an implementation plan. By the end of 2023 training course, online course, should be ICD 11 will be implemented. Tracy,
Yes, hi, we can hear you perfectly.
all right. Yeah, that's all. We don't have an implementation plan. So by the end of 2023, online training to be completed and the ICD 11 to be implemented.
Would you mind sharing a bit more about how ICD 10 is currently implemented in Samoa?
Yeah, there are some benefits for our coders. Once the ICD 11 implemented, indicating the need for additional guidance for coders and technical improvements. The work plan should be centered around the transition and implementation phases of ICD 11. We have to understand the guidelines and rules of ICD 11. And now ICD 11 is now officially in effect for the national and international recording and reporting of illnesses, deaths, and more, morbidity and mortality. And it has encouraged Samoa to move on to ICD 11 once they're implemented.
Wonderful. Thank you so much for that overview and the interest to progress to implementing ICD 11. So with this, I will now turn it over to Dr. Nina Kostensky, who will be sharing about the steps towards ICD 11 implementation and piloting. So I'll turn it over to you, Nina.
Yeah, thank you, Tracy. Can you enable the screen sharing? Okay, thank you. Can you see the slides?
Yes, we can see it perfectly.
Yeah, okay. So good morning to you, everybody. In this second presentation, we would like to give you an overview on the generic steps we see for the piloting of ICD 11 at the country level. And let me just start with a little bit of context. As you can see here in the slide, we see the piloting being part of the overall ICD 11 implementation plan for the country. And as you can see, this is, of course, a stepwise approach. And roughly, you can categorize it in these kind of 5 steps, starting with the kind of familiarization of stakeholders. And as we just heard from Samoa, and in fact, many other countries who went through this process already, it's very important to have this situation analysis on the current use of ICD 10, or wherever sometimes also 9 is used, vis-a-vis the current practice of coding mortality and morbidity, and very importantly also of how you actually use the data, what are the use cases. And then based on that, to really come up with an integration and piloting of the ICD 11 in electronic or paper-based medical documentation systems. So I just want to emphasize that even if the infrastructure of ICD 11 is electronic, you can still implement it in a paper-based documentation system. What has to be sure is that you run then the coding part on the local computers. And this is in fact what is happening in some countries where there is not yet an electronic medical record or electronic medical certification of causes of death system in place. So that would then, of course, where this is the case, integration of the APIs, as we have heard, in the software applications and other aspects which come there into the picture, and capacity building of the coding workforce training, etc. But I will elaborate on this a bit in the piloting part of the slide. Now, after that, obviously, what we would foresee is to have a scale up. So whereas the piloting would be in very selected settings, the scale up would be done nationwide, and then also the training which goes with it. There might be specific aspects which you also want to take into consideration, depending on how strong your legacy of ICD-10 is in the country. You may, for example, want to do double coding studies and other more in-depth studies which are needed to guide the transition process. If you have a reimbursement system which is running with ICD-10, obviously this is also requiring more intensive work in terms of scale up, so that the next step in terms of preparing the system-wide implementation, where you really switch from the old system to the new system, is well prepared, and you can make the switch with confidence, and then finally start reporting with the ICD-11. But all depends really on how strong the legacy is. That's why we make this distinction also. In some countries, they move straight into the implementation, whereas in others, we really talk about the transition process. But that's why it's very important to really contextualize the implementation in the local context. And the other aspect, of course, is that when we talk about the piloting and implementation, it is important to highlight that we want to keep the existing system maintained during the transition, so the piloting and implementation preparations run in parallel and without interfering with the existing system. For the national implementation plan, it is very important that from the very beginning, you seek leadership commitment and support from the political level. It is also very important, and we have seen this in a number of countries, to have the official ICD-11 focal point nominated, as has been communicated, I believe, from our colleagues in the regional office and from headquarters. There has been an official communication which went together with the letter by the Director General after the adoption of the ICD-11 in 2019 to nominate such focal points and to have a home for the ICD overall and the ICD-11 implementation and transition by creating a National Center of Excellence or a task force. That will be very important to institute. And we have also seen in a number of countries having this kind of political commitment by having a champion at the political leadership to steward this will be very helpful. Now, another important aspect is really to leverage facilitators. So if the country or if the sub-region, for example, has a national digitalization project in the health sector, or if there's any kind of process to modernize the health system or information system, linking the transition and implementation process of ICD-11 with this overall project on digitalization or modernization of the health information system will be very important. And any kind of efforts which are underway and sometimes also supported by some of the agencies like the bank or the Asian Development Bank will be, of course, instrumental to leverage in this context. Then, of course, all of this is a process of change. Now, that's why having the stakeholders, the multitude of stakeholders engaged and having effective communication throughout this process of transition will be very important. And last but not least, keep it simple, be pragmatic, and find solutions which are operational in your environment. That is the most important thing, so that you find a way of making it possible under the circumstances and under the condition in which you do the medical documentation in order to make the whole effort of transitioning sustainable. Now, when it comes to the piloting itself, what we foresee from a very general perspective and based on the experience we have now in a number of countries, to consider these are the kind of some of the main points to take into consideration here. The first thing is that make a good formulation of the use cases for where you start the pilot, whether it's in mortality or morbidity coding or both. And as I mentioned before, link with any kind of national initiatives. Then second point about formulating the objective. So for example, if your focus is on mortality coding, you can say you will aim to test real life implementation, and the emphasis here is on real life implementation of the ICD-11 coding tool for coding causes of death by, whether these are coders or medical doctors, whatever the situation is in your country, at facility level, at central level, etc. Those needs to be specified. Use the coded data set from the district hospital to test at central level. For example, the DORIS tool, which is a tool we have developed, which is digitalizing the mortality rules for selecting the underlying cause of death, and provides an automated way of assigning the underlying cause of death, and to use another tool, which is under code 3 for data analysis. So you see here, there is a formulation of the pilot objective, which is including not only data capture, but also assignment of underlying cause of death in the coded data set, and then the analysis of this data set with under code 3. So this is one way to formulate the objectives, but there might be many more. But the important thing is try to specify it in a way which is useful and feasible in your context. If you're thinking about morbidity coding, again, here would be a way to formulate this by coding the inpatient discharge diagnosis by medical coders in a secondary hospital, and perhaps you have primary healthcare centers which are equipped with physicians or nurses where it's done by the healthcare worker directly. Then specify the setting. Another important question is what kind of data you want to collect during the pilot. So what are questions you want to ask in addition to documenting the diagnosis? So for example, what we always recommend here is that you have a way to document the free text as it is written by the physician in the medical record, and other aspects which you see listed here. Specify what kind of questions what you want to ask the participants who are participating in the pilot. For example, did the coder or did the physician find what he or she was looking for? Was it easy to find the diagnosis in using the coding tool? How much time took it, etc. And then when it comes to analysis, think also of the different perspectives you may apply here, from a data perspective, from a user perspective. What are the lessons learned from this pilot in terms of implementation? Now, obviously, then moving forward in terms of real preparation, as we said, it's very important to make the pilot as realistic as possible. So try to mimic the real life documentation and coding and use the situation analysis. And based on that, do the pilot. So if you run a paper-based system, do it in that context. If you have an electronic system already in place or you're contemplating to put it in place, then it can be done in that context. So what kind of technology solutions need to be prepared before you start with the pilot will be very important to clarify. As I said before, ICD-11 can be used also in a paper-based system. What needs to be then ensured is that we have the ICD-11 coding tool installed in the either ideally on the local server at the facility level or on the computers which are used by the health workers or the coders, whether they're coders or physicians or nurses. Then, of course, issues around pilot organization and, very important, the training of the pilot participants, and then going through the other steps of pilot implementation, having some kind of support team established at central level, but also at the pilot sites, collecting the data and making sure that this data is analyzed, reported, and also disseminated and communicated will be very important in carrying the pilot through. So this is, as I said, more or less a high-level summary of the different steps which we foresee. But what is important is to take this, like we have also in the implementation guide, and contextualize it, operationalize it in the local setting where you are the expert, you know much better than us what exactly needs to happen in order to make it happen. And I just want to give you very few examples of implementation experiences and pilots, which started with a pilot here in Argentina in the area of mortality coding. They have been using their newly installed electronic platform for medical certification of causes of death, where they have started with a limited number of pilot sites, and now they're expanding this across the country for mortality. And they also have been testing the DORIS tool for automated selection of underlying cause in this electronic software application. Here in Belize, this is an example for mobility. In the beginning, there were a multitude of stakeholders which were interested, but at the end, it was the National Insurance Agency who was really keen to move forward because there was a pressing need to do so. And they also then assigned their programmers to make sure that the ICD-11 APIs and embedded coding tool is integrated into their insurance claim processing software. And that was the starting point for the pilot and then the subsequent implementation in the country. At the time, mortality colleagues were not that much interested, but this is also now changing, and they have started. In the UNRWA, this is the United Nations Relief and Work Agency, which is operating primary healthcare centers in all the Palestinian refugee camps. So they have a total population about of 6.3 million with about 140 primary healthcare centers. And their track record of ICD-10 coding has been very poor. And they had, starting with the pilot, also a very nice implementation of the ICD-11. And for the first time, they have now at primary care level, a detailed documentation of not only coded ICD-11 information on the diagnostic, but also information, but also on the main complaint or chief complaint by the patient, so that they can do the triaging in a much more systematic way, and also do very interesting ways of monitoring, for example, the consumptions of medications, which you see here captured in this slide. And again, the starting point was a small-scale pilot and then expanding it. Now, here you see the latest version of the ICD-11 based medical certification of causes of death app we have in DHIS2, which has been developed with the HIS Vietnam team and University of Oslo. Now there we have, for the first time, also an integration of what we call the end-to-end solution. So not only ICD-11 in the electronic form for medical certification of cause of death, but also integration of the ANA code 3 for data analysis, and in the latest instance of this software, also the DORIS tool. And that is now ready to be deployed, and there are a number of countries who have started using this. And for those countries who are in the Pacific Islands region using DHIS2 and are contemplating to start piloting in the area of mortality using the DHIS2 platform, this is definitely, we would recommend to leverage this, to make use of this. And please let us know, and we can then explore further on how to assist you in basically moving ahead with the use of this application for piloting purposes. Now, also as part of the pilot, it has been for many countries the starting point to give us and feedback to us information which helps us to improve the ICD-11 further in terms of its index, in terms of improving the natural language processing capacity, what Robert mentioned earlier. And you see here some examples from Tanzania back in 2017, where they provided us with a list of most frequently used diagnostic terms as they were found in the medical record and in the cause of death certificates and the paper-based system. And they made a very nice systematic compilation of this in the hospital in Zanzibar and also with the frequency. And it helped that a lot in terms of finding here and there. You see here on the right-hand side the comments by WHO, where at the time we had certain index terms missing. Some of them were generic, some of them were specific. And below you see also terms from the National Health Authority in India, where a similar exercise was done recently. And in another example, I show you here a recent compilation which the Ministry of Health in Chile did with clinical acronyms, which you also find now in ICD-11. And they have those which are highlighted here in yellow are included in the Spanish version with their frequency also indicated here. And we are now doing a systematic compilation across all the Spanish-speaking countries to enrich the index with clinical acronyms frequently used in all the Spanish-speaking countries to make sure that this is also expanded and that the clinicians or the coders find these acronyms in the index as well. So these are examples, and obviously we can do the same for the Pacific Island countries if you provide us with this kind of systematic analysis of your term base. If this is accessible or can be compiled, it might be useful to look at it from various perspectives. One of them is obviously the enrichment of the index, but also for training purposes, it can be very useful. And this brings me to the end, just to highlight that obviously from our side, we will continue across all the levels of the organization from headquarters through the region and the sub-region, the country office, to provide the guidance and assistance with our partners and collaborating centers in terms of the implementation package we have in place. And you see here listed some of these tools I mentioned earlier. Then the training and familiarization tools which are in place. ICD Fit platform, I think, has been used already in one of the trainings which was organized before, but we can set up centers for each of the countries to make more use of this or a group of countries. And then we also have an upcoming WHO Academy course, and the kind of curricula which has been there in place can also serve as a guidance for any kind of training which will be developed further. And as I already said, the direct country support together with our colleagues in the region and the country office will be always available for you to really guide you in this journey. So with that, I stop and thank you for your attention, and I hand back to Tracy.
Thank you so much for that presentation, Ninad, and for sharing all the examples and how WHO has supported countries in this process. And to further elaborate on the type of support that WHO has provided, I'm going to turn it over to Dilip Hansman, who's the coordinator of the Health Information and Intelligence Unit at the WHO Western Pacific Regional Office. So over to you, Dilip.
Thank you very much. A very good morning, a good afternoon, and very good evening to you in whichever part of the world you are from. So just to take you briefly through some of the support that we've been providing from WHO in WebPro. Basically, I mean, we support member states in the mission to ICD-11 transition, and we've been promoting a systematic approach to speed up ICD-11 implementation throughout the region through cross-sectional collaboration and resource mobilization among partners. So at regional level, we disseminate WHO strategies, frameworks, guidelines, tools, and develop the regional and support to develop the regional implementation plan. We also support the establishment of expert and peer networks in ICD-11. We're working with our collaborating centers across the region, And then we map and monitor countries' current situation and progress in terms of ICD-11 transition and create regional awareness campaigns, run regional awareness campaigns and advocacy. So this is all done through the four-stage process. We provide tailored country support to our member states in orientation and familiarization, planning and piloting, national scale-up, and routine reporting. Just to take you through where we are in terms as a region. Across our region, orientation and familiarization has taken place at least in 6 member states. So they are still at stage 1, and then we have at least 5 member states who have further developed their national implementation plans and roadmaps and initiating pilots. A number of countries, especially the non-UN standard language countries, are working on translations of ICD-11, including China, Japan, Republic of Korea. And then we have one country that has gone up to national scale-up or cross-sectional collaboration and enterprise planning, and that would be Malaysia. And I think it would be fitting to move here and have Dr. Irwin Wei from Malaysia, who has advanced considerably in ICD transition, to take us through the Malaysian journey. And I would like to invite Dr. Irwin to speak to us. Over to you, Dr. Irwin. Thank you very much.
Thank you, Dilip. One moment, let me just share my slide. So, am I audible? And if my slide, is my slide visible?
We hear you clearly, Doctor, and we
Right.
also see your slide. Thank you.
Right. Thank you very much, David. So, so good morning, good evening, everyone. I'm Erwin from the Ministry of Health, Malaysia. So today I'll be sharing with you regarding our journey with ICD-11 implementation and our progress so far. So this is the content of my presentation. So a little bit of my country. There are about 32.7 million of us. GDP per capita is 12,500 USD. 11.1% of our population is aged more than 65 years old. We spend 4.26 of our GDP on health, and the life expectancy average in Malaysia is 74.9 years. So these 4 areas are the areas of concern in health, namely the population health, people, financing, and delivery system. So this is our digital health landscape, as we have over here. The first bar over here is the national or the global commitment, like for example the SDG. Then for the national common infrastructure, you will have the MyGovNet, MyGovUC, MyGov enterprise architecture. Then for the governance and policy, we have public sector digitalization strategic plan. For standards and interoperability, we have health information standards, the dictionary, the Malaysian Health Data Warehouse, and over at the collaborative platforms, we have National Health Information Committee, WHO, or WIPRO, and so on and so forth. So for the ICD in related data collection and analytical systems in Malaysia, these, as you can see over here, the operational systems, it includes the EMR, or the health information systems, whereby these systems are integrated to the Health Management Information System, or the HMIS, that is the SMRP. Then the information from the HMIS will flow into the data warehouse, in which subsequently the data will be used for fixed format reporting, geographical mapping, dashboards, and KPI. ICD coding in Malaysia, we've had a long history of ICD coding. We've started with ICD 9 from 1986 to 1999, and we've been using ICD 10 since 1999. In 2014, we've decided to standardize the use of the ICD edition, that is ICD 10 2010 edition. Today, we are actually using a slightly modified ICD 10 2010 edition with the addition of COVID-19 codes. So there's the update that we have done so far, and we are transitioning to ICD 11, hopefully by 2024. So this is the implementation mandate, whereby you are able, I mean, this mandate is available. What we've used is the 72nd World Health Assembly mandate, whereby in which ICD 11 is made to be used, and also we've used the mandate in the WHO Nomenclature Regulations 1967, in which member countries are advised to use the latest version of the classification. So we have a few strategies that we'd like to share that has been working for us, and we hope you would consider it in your local setting. So let's go to the first one, initiatives and buy-in by national government agencies. In 2020, we've had ICD 11 virtual training organized by Wipro and facilitated by the WHO HQ. So the members of the virtual training included the middle level managers and also the decision makers. And to help us justify in getting the decision, to have that policy in place to get the decision by our top level management, we used the two documents that we've mentioned, and it has helped us greatly to convince our top level management. And with that decision, we have formed a working level committee, which complements the existing decision-making structure, which I will share with you later. Next, we have identified suitable agencies to undertake the transition. And in Malaysia, in the case of Malaysia, the Health Informatics Center under the Planning Division has the clear mandate to implement the ICD 11 across health systems, whether it's public or private healthcare systems. Besides that, the next strategy will be effective planning. After looking into our healthcare system, the infrastructure in our country, we have decided to separate it into a long-term and short-term and a long-term plan. The short-term plan, the goal is to, in essence, I will share that the short-term plan will be to report in ICD 11. Hence, it is the HMIS system that we are targeting for our current transition. And for the long term, we will be targeting the HIS or the EMR and other related systems. And as much as possible, our approach is that we do not want to have any significant disruption to existing work processes. Budgetary consideration, approximately improving the HMIS and the Malaysian Health Data Warehouse is costing us an approximate amount of $439,000 US. And for the HIS and other systems, it's costing us 2.2 million. US dollars. The reason being is we have, I would say, a mishmash of HIS systems. Some are off the shelf, some are proprietary product, some are owned by the Ministry of Health. So when you have different systems of different nature, so hence the cost has increased. And besides that, for the mapping purposes, we have also identified the need to map ICD, because as I've mentioned just now, we've been using ICD 10, 2010 edition. There is a need to prepare a mapping table between 2010 and 2019 edition. However, the documentations are readily available with regards to the changes. So what we have done is that we have identified what are the codes that have changed, and we've done accordingly based on that. After that, then only we use the mapping table that is being provided by WHO. Training-wise, we have separated into two. One is introductory training, and also another will be the certification training. As this a significant effort in our country, so we've decided to collaborate with any other agencies that have the shared interest with us. So in this case, for training purposes, we have collaborated with the National University of Malaysia in training. And besides that, we have also prepared an e-learning platform so that users are able to watch the videos while we try to reach them for the face-to-face training. And it's for, I would say, if those who have been introduced for ICD 11, the e-learning platform serves as enhancement of their existing knowledge. So optimizing health resources, as ICD is not new in our country, so we have the existing human resources with the assistant medical record officers, the medical record officers, or you may call it in your country health information managers, and etc. So very interestingly, we'd like to share what's the feedback from the users in the ground level. So every time when you try to introduce something new, the stress will be there, the anxiety will be there. So the normal response would be, hey, come on, as a national agency, why don't you give us more people? However, the thing is that to hire more people, it requires a long and tedious process, especially in our country. So while we are working on that, we have suggested, what we've done as a short-term goal is that we have revised the existing productivity, for example, data submission KPIs, and also data quality KPIs. Like, for example, currently for ICD 10, our KPI would be 95%, and we have revised it to 80% for on the first year of the transition. So users won't be anxious, will be less anxious while we try to get more people on board in the service. So coding guideline, to give confidence to our coders, we are in the means of finalizing our coding guideline. This coding guideline serves as gold standard codes for common diagnosis, for example, top 100 diagnoses in Malaysia. So the suggested codes will be there. However, we have to keep at the back of our head that this coding guideline is a double-edged sword, whereby once users are comfortable with ICD 11, there's a possibility that users will not want to code more if they get that kind of information. So this is what we are keeping at the back of our heads, but right now it works well for us. Next would be the information technology infrastructure and the vendor readiness. So we have engaged the same vendor who has done these two systems, and they are able to prepare two concurrent systems. So the coding of these two versions are able to run parallel. So for example, we are starting our piloting this September, involving 6 facilities in Malaysia. So these 6 facilities will code in the new system. It is similar, but it is the updated version, whereas the rest of 138 facilities in Malaysia will be coding as per usual in the existing system. Next would be the auditing. This is very much later while we are doing our piloting data. Again, we will be looking to the quality and the productive part, and reporting and research considerations that you may want to consider because of what Robert has mentioned just now with regards to certain diseases being shifted to another chapter. This will affect the current reporting in your country. So there are ways to handle these data. One is that you should anticipate this, and you have to quickly come up with like a note to inform before people start asking questions. Next, you could use the mapping table that is prepared by WHO, or if you in terms of you want to see the disease trends and you're afraid that there is an interruption in that sense. We've seen like many researchers in the past, studies in the past, they've used the interrupted time series analysis. So you may want to consider that in your trends reporting. So the items, the items or milestones that needs to be achieved, we have adapted from the ICD 11 implementation or transition guide, and also a literature review of previous transition strategies. So there are 3 priorities. Let's go to the first priority, that is human capital development. So what we've done in the early part of our transition, that means after the ICD 11 virtual training was, we identified the existing decision-making structure, and we try to complement the entity of ICD 11 into the current decision-making structure. So in this case, we've added the ICD 11 and EG implementation committee, which reports to the Standards Informatics Committee, and in return, which reports to the National Health Informatics Committee, which is chaired by the Director General of Health. This was what we've done in 2020. You'll say this is the first step. That is the organizing of the ICD 11 virtual training. Next, as I mentioned earlier, we developed a training platform and materials. The e-learning modules were developed with the cooperation of our local stakeholders. The teaching is recorded in the Malay language. And after that, as I mentioned earlier, we have coder training and certification. So far, we have 9 nationally certified expert coders, and we train and approximately 64 certified clinical coders in ICD 11 with close collaboration with the National University of Malaysia. Next would be the priority 2, infrastructure analysis and systems adaptation. We have explored, this was the initial part, we've explored with our IT unit and the information management division in the Ministry of Health. We found out that it's feasible to be done in the systems in Malaysia. And So upon the studies, we started applying for funds from the Malaysian government. And in June 2022, the system transition commenced. And this project is slated to be completed by May 2024. However, the ICD 11 part will be completed hopefully by September for us to start our pilot, and by January 2024, we'll be able to move completely to ICD 11. Next will be the coding guideline. As I mentioned, this is a double-edged sword. It's a quick reference guide with gold standard codes that has been agreed by all of our nationally certified expert coders. And in the coding guideline, we have a step-by-step guide to capture the terminology and also the ICD 11 code. So this is the wireframe of the system in the HMIS system. Next would be the adaptation to health information system. These are the short-term goals and the long-term goals that we have mentioned. So our short-term goal is to focus on the systems that's focused in reporting, in disease reporting at the national and international level. Long-term would be the legacy HIS systems update and the review of current workflow. This is the priority tree, the third priority. As I mentioned earlier, we reviewed the mapping table. The WHO's ICD-10 and ICD-11 mapping table, we have also improved on it by adding 5-digit and 6-digit ICD-10 codes. Besides that, we also reviewed existing laws and regulations, especially on the private healthcare facilities, whereby the clause whereby they have to send us regular reporting to the Ministry of Health. Next would be the impact analysis to existing data, hopefully to be done with the start of the pilot, which is this September. Next would be the data and the coding quality review. So some take-home points that I'd like to share with all of you is ICD 11 transition is not a simple switch of a button whereby the next day you are using ICD 11. It requires effective planning over at the national agency level. We hope that the suggested strategies are helpful and can be applied accordingly at your local setting. We also would like to share that changes brought about by the transition must not be too disruptive. We would like to work with what we have currently, whereby we have coders who do the coding. We would like that to stay until when our reporting is stable, when we have completed the transition process, then only we will look into encouraging the medical officers to code. Next is we like to share that it's important to communicate and listen to the users, listen to their browsers, and try to find solutions. Genuinely try to find solutions for them, as this is with regards to the existing workload. The KPI we think is a very good solution while we start the process of trying to get more appointment of the assistant medical record officers and the medical record officers. Then confidence. This is I would say lack of confidence is quite a challenge for us, and it spreads at all levels. So one must always keep a lookout for this, and you must find ways to secure everyone's confidence that this can be done. And always be ready to listen and again to reassure the users. So that's all from me. Thank you very much. Over to you, Tracy.
Thank you very much for sharing the experience from Malaysia, and wonderful to see all the progress that you have made. And I'm sure the success stories is really encouraging for the countries across the Pacific in terms of implementing ICD 11. And I'm sure the participants have a lot of questions for your presentation and also overall from all the information that we've shared today. And just to emphasize, this webinar is an introduction of the resources and tools available. We will be following up with more in-depth activities to provide more well-rounded and comprehensive information moving forward. So with that, I'll open up the floor for questions. And please feel free to unmute yourself or raise your hand if you have a question, or use the chat box also. So I think there was a question in the chat from Karen Nagmata from Cook Islands. So the question is whether we could have more information on the WHO Academy. Understand it's upcoming, if there is a concept paper on what this will entail. So could I turn this over to one of the colleagues from headquarters who may be able to provide more information on the WHO Academy related to ICD 11?
Sure. Can you hear me?
Yes, we can hear you perfectly.
Yeah. So let me perhaps share with you a quick slide so that you can see this. Give me a minute to share my screen. So we are in the process of producing the first module of the what we call ICD 11 e-learning course. And this first module will focus on basic coding with ICD 11, and where we give emphasis on basically interacting with the coding tool. But as you can see here in this slide, the starting point for all this is to really rethink ICD training and highlight that we need to apply certain design principles in approaching the training by focusing on the competencies for different target groups, for example, medical coders versus physicians, that we start what we call with an inside-out approach from the basics to the more complex issues, use problem-based learning, give learners a sense of benefit, leverage technology, and also use different media. So what you see here is the outline of this storyboard for the first module. And as you can see, the emphasis is really on interactive training for the coders to basically demonstrate the...
Sorry, Nenad, we don't see your slides.
Oh, I'm sorry for that. I thought it's sharing. Can you see it now? The screen?
Not yet.
Okay.
Yes, it's coming.
Okay. So this is what I was mentioning before, to apply these principles and rethink our approach to training to make it more focused on what kind of competency we are training, who is the target audience, keep it simple, and then move from simple to more complex issues, trying problem-based learning, and give learners the sense of benefits, leverage technology, etc. And accordingly, you see here an outline of the curricula which has been put in place for these different modules. We are developing it now. The one for basic coding is already in place, which are specifying the intended learning outcomes and the content. And this is a sample of the lesson structure for the first module, basic coding with ICD 11. And you notice that the emphasis is here very much on teaching how to use the tooling environment of ICD-11, the coding tool, and how to post-coordinate, etc., in a very interactive style. This is another screenshot of the detailed learning outcome and curricula. And here some samples of screenshots of the storyboard. So this is just to give you a flavor of how this training, is approached. And we would definitely recommend that whatever is done at country level is picking up on that and leveraging this. And once the course, we expect this first module to be, as I said, it's currently in production, and we expect to have it up and running by the end of this year, that it will be then also of benefit for the countries to make use of. Other modules will focus on more in-depth mortality, morbidity coding, a general introduction into ICD-11, and then some other specific aspects related to specialty areas of morbidity coding. The other important information there is that we also envisage that together with this training, WHO and the Academy, WHO Academy can team up with national certification authorities, as Erwin, for example, alluded to, so that there is a possibility to think about a joint, let's say, micro-credentialing for coders with ICD-11, something which we were always hoping for in the past, but given the kind of circumstances and the arrangements, this was not possible to implement. But with the Academy in place, this is definitely on the horizon, and we are working towards this. So I hope that gave an answer to the question. Thank you.
Thank you very much for that overview of the planned course in the WHO Academy. So I hope that answers your question, Karen. And I think this will be a very essential resource as countries start to implement ICD-11. So moving on to the next question, I am mindful of the time. So there was a question in terms of, will PICS be supported in creating an implementation strategy plan to have ICD-11 in country to identify our gaps and needs that will be required to have ICD-11. So most definitely, this is a key priority for us at WHO. We look forward to collaborating with each of you in terms of conducting the assessment and implementing the various steps that have been introduced throughout this webinar. So before we close, any quick questions from anyone on the call? Please feel free to raise your hand or to mute yourself directly. If not, I just want to take the time to thank you, all of you, for taking the time to join this webinar, particularly for our colleagues at WHO headquarters, given the large time difference. And we look forward, and as mentioned, this is one of the first webinars, and the future webinars will take place in each month, and the next one planned will focus on WHO resources and tools available. So there will be an invitation that will be sent out to you shortly. And to get a better sense of the information that you would like us to cover, I'll be sending an evaluation form just to get your thoughts on the topics that should be covered moving forward. And with that, I would like to thank all of our presenters, particularly from the country representatives from the Ministry of Health in Malaysia, and also from Samoa, and also across the 3 levels of WHO as well. So thank you very much, everyone, for taking the time for this webinar, and hope you have a good day, good evening, or good afternoon ahead, depending on whichever time zone you are at.
Thank you. Bye-bye.
Thank you. Bye-bye. Bye-bye.
Bye-bye.
Thank
Thank
you.
you.
Bye,
Thank you,
everyone.
everyone.
Thank you.
Thank you. Bye-bye.
Now it's meeting. Okay.
Hi, thank you.
Bye.